Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
Off-label therapies have not been approved for the use specified in this activity. This information should not be considered as a recommendation for the use of a drug outside of the recommendations in the currently approved prescribing information. This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from AstraZeneca.
Hello and welcome to this program entitled HER2-Positive Early Breast Cancer, What the Latest Data Mean for Your Practice. I'm Judy King, Consultant Medical Oncologist at the Royal Free Hospital in London in the UK. And joining me today is Charles Geyer, Professor of Medicine at the University of Pittsburgh Medical Center in Pittsburgh, USA. Welcome, Charles.
Thank you, Judy.
So let's get started. Let's briefly just talk about the current management of patients with HER2-positive early breast cancer. And there are, as we know, current ESMO guidelines, which by and large, you can either have primary surgery and adjuvant treatment or neoadjuvant treatment. And for the vast majority of patients, if they have a cancer that's less than 2 centimeters, so T1 cancers would tend to have surgery and then adjuvant chemotherapy and HER2 antibodies. And for those bigger cancers, so T2 and above, or anyone with node-positive cancers, they would tend to be offered neoadjuvant treatment with a combination of chemotherapy and anti-HER2 directed antibodies. But I think when we think about the unmet need for these patients, it's sort of twofold. That T2 and above group is a very broad church. And there's a big difference between, let's say, a 22 millimeter cancer, which is node negative, and a 6 centimeter cancer with 4 or 5 lymph nodes involved. So knowing when to escalate and when to de-escalate treatment is a really important area to discuss. And so with that in mind, let's start talking about the adjuvant setting, because we're all aware that after neoadjuvant treatment, those patients who do not achieve a complete pathological response are at higher risk of relapse. So Charles, let's talk about the latest data from the Destiny Breast 05 study and as it compares to the standard of care, Catherine with TDM1.
Sure. Just as a reminder, Catherine was a study that we actually reported at San Antonio back in 2018 that did change our standard of care to the neoadjuvant setting for patients that Judy described, those with T2 tumors, positive lymph nodes. That was a trial that we randomized patients who did not have a pathologic complete response, who had presented with at least a T1C N0 tumor. We excluded T1A, T1Bs. So a broad brush of patients just had residual disease, did not have a pathologic complete response, and they received what at the time was standard trastuzumab or TDM1. Destiny Breast 05 was a follow-up study to Catherine that basically used the same approach, except it focused on the patients who already were having a higher than ideal risk at the 3-year mark when we first reported Catherine, the unmet need patient population who came in with larger tumors or who had positive lymph nodes after surgery. We, really were focusing on that group. So this is why the studies have different eligibility criteria. You really need to think of DB05 as a follow-up study to Catherine to address unmet need from Catherine. I think it's interesting to look at the forest plots at the 3-year invasive disease-free survival, because you can quickly see why we picked patients who had presented with inoperable disease or who had positive lymph nodes after surgery. They already were having a recurrence rate of approaching or exceeding 20%. So this was the group that we basically focused on, the unmet need. When we had our 7-year follow-up data, our mature follow-up data of Catherine, we were very gratified to see the IDFS improvement. That 50% reduction really held up out to 7 years. We saw survival benefit. I do think when you interpret the DB05 data, it's useful to look at the long-term Catherine data and see how patients did with TDM1 at 7 years, not at 3 years, because it really reflects the future for the patient. And I think that's the point that one should look at. And you can see when you look at the tables that even groups that were not included in DB05 still, to me, have a bit of unmet need. So what did we see on Destiny Breast 05 in this high risk population that we chose because they already at 3 years had an unmet need identified? Very gratified to see a hazard ratio of 0.47, substantial improvement in the early 3-year IDFS from 83.7 to 92.4%. Secondary endpoint of distant recurrence-free interval was also very strong because most of the events were already distant recurrences. And we're seeing an early signal that perhaps TDXD was going to impact on the brain metastases issue that we did not see with Catherine. Survival was also trending in the right direction. When you again go to the forest plots, it's very gratifying to see benefit through all subsets in the trial. And I think there's a lot of interesting data when you look at individual subsets of patients that always are helpful when you're counseling individual patients. The one thing we didn't have when I reported the study at ESMO was how patients did with HER2 2 plus versus 3 plus. In Catherine, we saw that group actually initially prognostically seemed to be a bit better than the 3 plus, but with further follow-up with TDM1, they wound up with a 30% recurrence rate. And we see here from DB05 that the 2 plus patients are particularly deriving substantial benefit from the TDXD relative to the TDM1. The big caveat, of course, when we took TDXD into the early setting was the ILD problem. For safe, we knew these high-risk patients were going to need radiation therapy, so we built in serial CT scan, low-dose non-contrast CT scans to try to identify ILD early so we could hold the drug, intervene, and not have patients develop severe toxicities. This is the data that we reported. TDXD overall, we had a 9.6% incidence. Thankfully, 8.5% of the patients were in grade 1, grade 2. We did have 2 deaths. We did have grade 3s. Initially, we didn't have a lot of granular information on that. Dr. Loibel at San Antonio reported that the median time to onset was 74 days with a range of 46 to 106. When it occurs, it takes a while for it to resolve. So it is an important aspect of the treatment that has to be kept in mind as we use this in early breast cancer.
Yeah, so I thought this was a fantastic study. I thought that this was, one of the big hitters that we were all waiting to see. I did think it was practice changing. I absolutely take your point about wanting to see the follow-up data, beyond this time point. But I think this was one that, this is a high-risk population. We know with the non-path CR, there are still patients who aren't going to do well with TDM1. So this is a real, something really important in the arsenal for these patients. There are some issues though. 6 weekly CT scans, the ILD risk. I mean, we'll go on to talk about DB11 in a minute, but do you think that this is, I suppose if people have gone with a neoadjuvant regime and have not got a PACR, this is a very good option for these patients. But do you think there are going to be issues in terms of delivery?
I think the implementation of the serial scans into routine practice is going to be a definite challenge because we're asking or asking our radiology departments to schedule a test. It's usually a diagnostic CT that's looking at the entire thoracic cavity, and basically saying focus on the lungs, look for ILD, use low dose, don't do contrast. So there's going to be challenges in communicating why I'm getting the scan, how it should be interpreted, and what am I looking for. I know here I've talked with our radiology departments about this, and I've come to learn a lot about the granularity of how modern diagnostic units work. A lot of it is tied into the actual code for the test. It's not so much our what we say, it's the code. So I think people are going to have to look at developing with their radiology departments a specific code that outlines that this study, how you do it, how you read it, or it's going to really cause a lot of chaos. You also have to schedule that study very quickly, because if you're doing it at every 6, 9, 12 weeks, that there can be challenges with getting scheduling done. So it is going to be an issue.
One more thing on the to-do list. Well, it's also not the only option. So what we have seen is ILD risk increases with number of cycles of TDXD. But let's have a look at the other trial that was also presented at the same time at ESMO 2025, which was moving TDXD into the neoadjuvant setting. So this was the Destiny Breast 11 study. And to cut a long story short, there were 3 arms. The TDXD arm alone was discontinued. So there were basically 2 arms to the study. One was a standard dose-dense anthracycline, followed by taxane and dual HER2 antibodies. And the second arm was replacing the anthracycline with 4 cycles of TDXD. And then again, followed by the taxane and dual HER2 antibodies. And the primary endpoint was PathCR, with all the standard secondary endpoints that you would expect. So I think everyone was very impressed with the data. In the intention to treat population, the delta in PathCR was an increase by over 11%. And when you looked by ER positive versus ER negative, in those very chemosensitive patients, so the ER negative group, the delta was 16% and actually achieving a PathCR rate of 83%, which is the highest PathCR rate that's been recorded in clinical trials to date. Some of the other secondary endpoint data, like event-free survival and so forth, remains relatively immature, but the signals at the moment are very encouraging. So this is interesting because it's just 4 cycles of treatment. And so when we look at the toxicity, it was very, very similar to what was seen with the anthracycline. Lots of discussion about this study. A lot of people don't use the anthracycline regime. They would have used more like a taxane carbotaxol or something like that. There are also issues with what to do with the non-responders. Goodness knows what we do if these patients don't get a PathCR. But when I've been speaking to colleagues, Charles, I don't know what your experience locally has been. I find that the discussion is very mixed. There are some people saying, let's get it in early. Let's give it neoadjuvantly. 4 cycles and you're done. Get the PathCR, and then you don't need to worry about the adjuvant setting. And there are other people saying, do it the standard way. For those patients that don't achieve a PathCR, select those for the TDXD. What are people saying in your neck of the woods?
Definitely mixed. I mean, it's because the results are not surprising, really, for either study. I mean, I think when these studies were designed, expectations were they were both going to meet their primary endpoints. The drug is so active in metastatic disease, it isn't surprising to see it. To me, it really gets to be, what was the purpose of the trial? The DB05 was to definitively address the efficacy in the highest risk patients. We have that. We know that the drug has a major impact on IDFS early on in high risk patients across groups. DB11 tells us that, well, we can substitute TDXD for AC if you use that regimen and increase the PCR to an impressive degree. It's encouraging that the EFS is in the correct direction, but we know that the adjuvant therapy has a major impact on outcomes. So I don't know how we'll be able to interpret the long-term data from that trial. It's really underpowered for that endpoint, but it will be interesting to see. For me, and the other thing about it is it did show that you have less ILD, which isn't surprising. You get 4 versus 14, and you have half as much ILD. And you saw from the DB05, it took about 4 months to reach the median point for developing. So it's all very consistent data. Uh, but I think the challenge is, as you alluded to, is what do you do with the non-PCR patients? And are we going to have data to tell us what to do, or do you just, and for me, I'm thinking about it. If I used it, if I had somebody who had, RCB1 where I felt like they really regressed, but with just 4 cycles, they didn't quite go there. Should I, finish, give 10 more to reach the 14? If it just sits there, what's the point? But what else are you gonna do? I think there's a lot of challenge there. You can it's great for your PCR patients, but the non-PCR patients, I think there's a lot of question. I'm less concerned about the control arm. Yeah, a lot of people have gone on from the anthracyclines, but I think the TCHP and the AC-THP outcomes are pretty similar. So I think you kinda can I'm okay inferring that control arm. I don't
I agree. I don't think there's a huge difference. You would expect it to be, a similar magnitude of benefit. I mean, I suppose there's also some in the same meeting we did see some data from de-escalation trials, not necessarily in this high risk population, but around the sort of more like the stage 2 patients that we had the neocarp study suggesting that we could perhaps de-escalate the chemotherapy and rather than TCHP, could it be just a taxane with HP? And so some of the clinicians that I've spoken to have suggested a maybe a more response adapted approach. Could we start with standard sort of taxane and dual HER2 antibodies, and for those patients that don't appear to be responding after 4 cycles, then escalate at that point? Now, I have to say, in the UK and other countries, in terms of the reimbursement, there are some countries where they take the trial absolutely to the letter and say you will only be able to do the order of sequence that was allowed in the study, but other countries have more flexibility. So, do you think that's something that people might look at?
I mean, here in the US, that's definitely what we're doing. That's where people are
Right.
going to follow up trial designs, and I think the DS it was we had a de-escalation theme at ASCO and then an escalation theme at ESMO. So it's kind of and I think it makes sense to move the THP up front. We see it gets a lot of people where they need to go, and so
Exactly.
I think we're headed towards de-escalation ultimately is how we manage these patients.
I think my real take home was having spoken to a lot of people, some people are absolute sort of DB05 converts, some people far more DB11. I think there are just two very good options here. But as you say, and neither one is necessarily wrong. So it may just be that there are two ways that you could go that will serve your patients well. So that on its own is a positive result for our community. But as you've said, this sort of de-escalation question, we can't be escalating and de-escalating at the same time. So really teasing out who's going to benefit is remains the tricky bit. It's also important, I think, to be aware that this is not the only drug in this space. There are lots of ongoing studies with ADCs in the adjuvant and the neoadjuvant space. So we'll be looking forward to seeing the readouts to those in the years to come. But for now, I think we're almost out of time. So, Charles, I'd like to thank you for your time and that great discussion. And for those of you watching, thank you for participating in this program. Please continue to answer the questions that follow at the end of this. Thank you very much.